Hi, this is Andrea Kane, and I'm here with you for HIT 120 Pharmacology. We are now on week 8. We are starting into the chemotherapeutic agents this week. We're going to be covering chapters 25 through 29. On week 10, we'll pick up with chapter 30 and go through chapter 35. But this week, as has been our usual, our unit objectives in our syllabus are 9.3.1, 9.3.2, 9.4.1, and 9.4.2. So again, we'll be focusing this week on antimicrobials. All right, let's take a look. We'll be talking about a quick introduction to chemotherapy. Then we'll be getting into cell wall synthesis inhibitors. Then we'll be talking about protein synthesis inhibitors. We will be touching on sulfonamides, not folate antagonists. The book says folate antagonists, but they're really sulfonamides. And then the book said quinolones, but it's actually fluoroquinolones. So just make those notes, those changes as we go through there. There are 4 types of cell wall synthesis inhibitors that we're going to study. Those include penicillins, cephalosporins, carbapenems, and vancomycin. Then there are 4 types of protein synthesis inhibitors that we're going to study this week. Those include the aminoglycosides, tetracyclines, macrolides, and clindamycin. Please note, before we get started, there are no drugs, and you need to know this for the quiz, there are no drugs that both inhibit cell wall synthesis and protein synthesis. They either do one or the other. They don't do both. And sulfonamides and fluoroquinolones don't do either one. So as you're going through and you're thinking and studying for your quiz, mentally group the first 4 under cell wall synthesis inhibitors, the second 4 under protein synthesis inhibitors, and then know that sulfonamides and fluoroquinolones are neither one, and there are none of these drugs, none, that do both cell wall synthesis inhibiting as well as protein synthesis inhibiting, because you will need to know that for your quiz. Hint, hint, hint. All right, moving along. Introduction to chemotherapy. Some general principles. Useful antibiotics, again, notice that word useful, are compounds that inhibit the growth of bacteria without harming the person. When we get into talking about harming the person, it may be a little bit more of the actual traditional chemotherapy drugs that you're thinking of that have a lot of toxicity. But useful antibiotics are compounds that inhibit the growth of bacteria without harming the person, and the drug should penetrate tissues to reach the bacteria. Okay, keep those things in mind. Spectrum. There are 3 spectrums: narrow, broad, and extended. This is a range or class of bacteria that the drug is effective against. So for instance, a narrow spectrum drug is only effective against very few bacteria ranges or classes. A broad spectrum drug is effective against many ranges or classes of bacteria. An extended spectrum drug is a narrow drug or a broad one, it could be either one, that has been added to when it was created in the lab to increase the range and class of bacteria that it's effective against. So it should make sense. Narrow spectrum means it only goes after a few classes or ranges of bacteria. Broad is it goes after a lot. Extended means it was narrow or broad, but it has been increased in its range or class of bacteria that it's effective against through its changes when it was created in the lab. Drugs can be bacteriostatic, meaning that they stop bacteria from growing. They can be bactericidal, meaning they will kill bacteria, and they can do both. So you may have one drug that's bacteriostatic, it stops the growth of bacteria. You may have another drug that is bactericidal that will kill bacteria. It may not stop it from growing, but it'll kill it. And then there are some drugs that can actually do both, not only stop that growth, but kill it. So make note of that. Hint for your quiz that you know that some drugs can do one, the other, or both. Resistance of bacteria to an antibiotic can be by 3 different ways. It's thought to be by 3 different ways. How does this happen? It can be by mutation. It can mean that the bacteria, that an antibiotic used to stop or kill the bacteria, but the bacteria has mutated, and your book talks a little bit about this, to the point where now that antibiotic no longer works. The second way it can cause antibiotic resistance is that the bacteria learns to adapt or alter. It alters itself, and or it adapts. And again, your book explains this. The third way is gene transfer, where small pieces of RNA, DNA get involved, and it alters the bacteria or it alters the cells to the point where the antibiotic no longer works. So again, for your quiz, make sure that you know how bacteria can become resistant to an antibiotic. Happens by mutation, adaptation or alteration, or gene transfer. Those 3 ways: mutation, adaptation or alteration, or gene transfer. Those 3 ways. All right, adverse effects. These can be allergic, toxic, idiosyncratic, meaning because of the treatment, or related to changes in the normal body flora. We have bacteria in our body that is normal, healthy, good. It's when it gets beyond what it should be, or when it gets way less than it should be, that we have problems. And we'll talk about that a little bit further as we get in and we talk about specific drugs. Combinations of antimicrobial agents can take advantage of the mechanisms of action to produce a synergistic effect. Remember when we talked about synergism? It's not just putting 2 drugs together and getting the benefit of both. It is putting 2 drugs together that when they play off each other, they actually give an even greater effect than the 2 together. That's the synergistic effect. So you will find as you are coding charts or you're going through and you're reviewing, auditing, those types of things, you'll notice that they don't always just do one antimicrobial agent. Sometimes based on the patient, they'll give them 2 or 3 of these antimicrobial agents because they know they work together and they'll get a bigger bang for the buck rather than just giving 1 or 2. Culture and sensitivity testing will determine the minimum inhibitory concentration for the bacteria. Now I want to stop here. MIC, if you see those 3 letters, MIC, you need to be thinking minimum inhibitory concentration. Minimum inhibitory concentration. What this is it is the lowest concentration of the drug that is tested through culture and sensitivity that will stop the organism's growth. So let's say that you have some bacteria, and just for the fun of it, we'll call it staph or strep. You choose. They take that bacteria, they put it on the culture plates, and they grow it out, and then they start testing the bacteria on those culture plates for sensitivity. So they might put penicillin in one area. They may put a cephalosporin in another area. They may put a macrolide in another area. They may use vancomycin in another area. They may choose to do a fluoroquinolone in another area. And they look at all those segments in the culture to see which one is the most sensitive to that bacteria, to that organism. And they look to see what's the low, first of all, which one is the, which one do they see is actually effective against the organism. So they're looking at that. But what they're really trying to find out is this MIC, this minimum inhibitory concentration, because not only will the MIC, the MIC, show you the lowest concentration of the drug that inhibits the growth, but the drug that the organism is most sensitive to will have the lowest MIC. So in other words, if in our example, the penicillin had the lowest concentration that caused the growth to stop, that is the drug that you want them to use to treat the patient, because it means that drug is the one that the bacteria is most sensitive to, and it will have the lowest MIC, the lowest minimum inhibitory concentration. So make sure that you understand this, that with culture and sensitivity, you take the bacteria, you culture it out, and then you start testing for sensitivity using different drugs, using the different antimicrobials. And the one that reacts, that stops the growth at the lowest concentration of the drug, that's the one you want. That's the one that the organism is most sensitive to, and it's the best one to use to treat the patient. So please make sure that you understand all of that. All right, so classification of antimicrobials, there's four overall groups that our antimicrobials are going to fall into. Cell wall synthesis inhibitors, protein synthesis inhibitors, sulfonamides, and fluoroquinolones. Now, we're not going to get down into the weeds this week. We're not going to talk about exactly what is cell wall synthesis and what is protein synthesis. Pretty much, I think you can tell from the name that these drugs stop that synthesis from taking place either at the cell wall level or at the protein level. And that's really all you need to know. And then there's the sulfonamides and the fluoroquinolones, and we aren't even going to get into talking about how they do what they do. We could be here all week. All right, so quick quiz questions for you to be aware of here in this first section. Be able to tell me what is a narrow spectrum drug, what is a broad spectrum drug, and what is an extended spectrum drug. True or false? All drugs are either bacteriostatic or bactericidal. They are never both. We talked about this. What are the 3 ways bacterial resistance to an antibiotic occurs? Remember, I covered those 3 ways for you. What are the 4 types of adverse effects of antibiotics? And if you're not sure about that, right back up here. Adverse effects can be allergic, toxic, idiosyncratic, or related to changes in the normal body flora. Those are the 4 ways. So I just gave you that one. How's that? All right, true or false? Combinations of antimicrobial agents can take advantage of the mechanisms of action to produce a synergistic effect. What does MIC stand for? What does the MIC tell us in terms of a specific drug and its concentration? True or false? The drug with the highest MIC means the organism is most sensitive to it. And what are the 4 types of antimicrobials that we're studying this week? All right, so moving on to bacteria. This just is here for you in case you are ever curious about gram-positive versus gram-negative bacteria. This just gives you some examples. You don't need to know any of this. It's just here so that if you are curious about when we talk about gram-positive bacteria, what are some examples? When we talk about gram-negative bacteria, what are some examples? All right, how does antibiotic resistance happen? And you studied a bit about this week with your discussion, but I want to cover it again here. Antibiotic resistance happens when you have lots of germs, and a few of them are drug resistant. And in our slide here at the top left, the germs are in the blue-gray, and the drug-resistant ones are in magenta. The first step is that you have lots of the bacteria, and a few are drug-resistant. The second step is that antibiotics kill the bacteria causing the illness, as well as the good bacteria that protects the body from infection. Basically, antibiotics don't know how to differentiate between the two, and they just go in and they say, oop, it's bacteria. I'm going to kill it, whether it's good or bad. They don't have the discernment to say, ooh, this is good bacteria, you need to keep it, and we won't attack it, versus this is bad bacteria. They just see it as bacteria, and so therefore they go after it and kill it. So what does that do? Well, it leaves the drug-resistant bacteria, and those are now allowed to grow and take over. And some bacteria then give their drug resistance to other bacteria, which causes even more problems. So that's how it's thought to happen, sort of on a microbial level. The next piece here in the bottom right of your screen is the 5 areas that go around that circle. The circle says infectious complications. due to MDRO. MDRO stands for multiple drug resistant organisms. Make sure you know that. Multiple drug resistant organisms. Okay? There are 5 risk factors. These 5 risk factors increase your risk of getting an MDRO, a multiple drug resistant organism. Invasive devices. Think catheters, PICC lines, things like that. Frequent exposure to antibiotics. If you're on courses of high strong antibiotics in short periods of time, that can cause you to have an MDRO. Exposure to exogenous organisms. A good one to talk about is MRSA, methicillin-resistant Staph aureus. MRSA, MRSA. We all have MRSA on our skin. And most of us don't have a huge amount of it. We have a little of it because on the outside of our skin, it's a good thing to have, and it kind of beats off other bad bacteria. However, if you go in and you have surgery where your skin gets opened up, some of those exogenous organisms, some of that MRSA, can slip in, and then it causes problems. A good example of this is hip and knee surgeries. Right now, they test patients for MRSA when they come in to see if they're a MRSA carrier, if they have quite a population of MRSA on their skin. If they do, they go through some extra steps before they have surgery, as well as after surgery in terms of antibiotic use, to try and minimize the amount of MRSA that could possibly get into that hip or knee replacement area and cause post-op infection. But it's not, we all have different bacteria on our skin. I mean, and we all have the same too. I mean, we all have a little bit of everything that we need, our bodies need, but it's when it moves from outside our body, inside our body, that's when we have problems, and we can sometimes catch that multiple drug resistant organism infection. Another risk factor for getting an MDRO is poor infection control practices, and I'm going to show you a slide about that in just a little bit. That means not hand washing or not hand washing properly, not sanitizing hospital rooms and hospital equipment properly, all those types of things. And then altered immunity. People who don't have a spleen, maybe they've had it removed after an accident or some type of healthcare issue, who don't have a spleen, or maybe someone who's been through chemotherapy and they have their immune system is much more fragile or vulnerable than some of the others in our community. Those folks are at much more of a risk to getting an MDRO, which makes perfect sense. So make sure that you're familiar with these 5 risk factors for getting an MDRO, and make sure that you know what MDRO stands for. Multiple drug resistant organism. And here we go on to the next one. So what is a multi-drug resistant organism? It is germs that are not killed by many different antibiotics. These illnesses caused by MDROs cannot easily be cured by commonly used medicines. These germs are easily spread from other people. They can be spread in a number of ways. It can be through touch, it can be through airborne, it can be through contact, it can be through touching something and the bacteria's on it. There's just all sorts of things. If a patient becomes sick from an MDRO, they stay longer in the hospital and are at a higher risk of dying. That's why it's so important. And then here are some common MDROs and their abbreviations that you may have heard of. I was just talking about MRSA or MRSA. It's methicillin-resistant Staph aureus, Staphylococcus aureus. And we're going to learn about methicillin this week. You'll learn that it's a type of penicillin. VRE, vancomycin-resistant Enterococcus. Vancomycin is another antibiotic we'll be learning about this week, and it's one of the most powerful ones. So if someone develops VRE, all of a sudden one of our most powerful antibiotics, vancomycin, is no longer available to treat them. Then you have MDR, Acinetobacter, Klebsiella, Enterobacter, Escherichia coli or E. coli, and then C. difficile, Clostridium difficile. These are all common MDROs. All right, hands can often be the culprit. They don't necessarily need to be the only culprit, but they are a common culprit. MDROs are spread from one person to the another, especially on the hands. Hands become soiled when touching the patient to give care or when touching surfaces in the room to which the patient or other caregivers or even visitors have touched. When hands are not washed or gown and gloves are not worn in contact isolation rooms, the MDRO is more likely to be passed to another patient because the caregiver is picking up that MDRO, and if they're not making sure that they are cleaning themselves very carefully and anything that they have with them before they walk into the next patient room, they can be moving those bacteria from one patient to another. Wash your hands. Why should you wash your hands? This is a culture where they had a nurse put her hands on the culture plate and they grew it out. That's the one on the left. That's the one where the MRSA grew after no hand washing. The one on the right is after using alcohol foam to wash hands. No MRSA grew. A good visual for all of us, even those of us at home with our families. Hand washing is really important, and washing doorknobs, cleaning or sanitizing doorknobs and toilet handles and sink handles and anything that we all touch that where we could pass it to another person. Light switches. I always have to remind myself when I'm cleaning the house to grab a wipe, like a Clorox wipe, and wipe off light switches and other areas that we all commonly touch. All right, we are now ready to jump into our first section of antimicrobials, and we are going to talk about cell wall synthesis inhibitors. And the first one we're going to talk about are penicillins. Penicillins, that is one of the most common antimicrobial drug out there. These attack gram-positive bacteria. Some narrow-spectrum penicillins are penicillin G and B, and methicillin. Remember we talked about methicillin-resistant Staph aureus as an MDRO? Here you go. Methicillin is a narrow-spectrum penicillin that's used to target gram-positive bacteria. Broad-spectrum penicillins include amoxicillin and ampicillin. Has anyone ever had a child and taken them to the doctor and the doctor has prescribed amoxicillin? It is a broad-spectrum penicillin that's there to target gram-positive bacteria, such as those that cause strep throat and things like that. Extended spectrum penicillins, I gave you a couple of generic names, but you don't need to know them. Please make sure that you know penicillins attack gram-positive bacteria. There are penicillin and methicillin and amoxicillin and ampicillin. So notice all of these end in cillin. If you see cillin, you know it's got to be a penicillin. And you need to know that it attacks gram-positive bacteria. The most significant adverse effect of penicillins is anaphylactic shock, and I know that from personal experience. When I was 19, I was on penicillin, and I don't remember if it was a sinus infection or something, or a tonsillitis or something like that. And I had taken penicillin throughout my childhood, never had a problem. And I had a situation of anaphylactic shock. And I was just really blessed. My mom's a nurse, and we lived maybe 5 minutes from the doctor's office. And she saw me struggling to breathe. I had hives. I was starting to feel really woozy and all of that. She recognized what it was. She had me use my asthma inhaler, and she threw me in the car, and we took off for the doctor's office, and I was able to be treated with adrenaline and more asthma medication to open up my airways and things like that. But I learned the hard way that yes, penicillins will cause anaphylactic shock. So that is not good. All right, so moving on. Cephalosporins. Here we go, cephalosporins. These also target gram-positive bacteria. These are divided into generations, and you probably don't really need to know a whole lot about the generations. All of them are similar to penicillins, but the first generation ones and the second generation ones are the most similar. So you can have a cross allergy with penicillins. I have done that as well. I have an established anaphylactic shock reaction to C-chlor, because after the penicillin they switched me to C-chlor and I reacted to that. So these two are cephalosporins and penicillins are very, very similar in how they act, how their nature is, how they're designed, all of that. So if someone's going to have a reaction to a cephalosporin, they're likely to have it for penicillin. And if they have a reaction to penicillin, they're likely to have the reaction to the cephalosporin. So just keep that in mind. Going back to the generations, the ones that I really want you to know are third and fourth generations. Third generations are for hospital-acquired infections. And if you do any coding in a hospital-based setting, like for an intensive care unit or something like that, you will see Rocephin given in the ED, in ICU, in different places like that. Ceftriaxone is the generic name, but the brand name is Rocephin. Make sure you recognize that as third generation cephalosporin for hospital-acquired infections, or to give in the hopes that if the patient has one, they can eliminate it, or if they don't have one, to prevent it. Fourth generation cephalosporins are for MDROs. That's what they were designed for. So you will see cefepime given in, again, ED, ICU. A lot of times you'll see Rocephin and cefepime given for septic patients who have sepsis or septic shock. Those are often given for that. So make sure you know cephalosporins, they target gram-positive bacteria. They are very similar to penicillins and have a cross allergy with penicillins. Third generation drugs, third generation cephalosporins are used for hospital-acquired infections. Fourth generation cephalosporins are for MDROs. Please be able to recognize these drug names. The generics come first. The brand names are in parentheses. Also, please make sure that you note cephalosporins can have anti-vitamin K effects, and we just studied vitamin K not too long ago. Well, let's talk about that. What does vitamin K do? Vitamin K thickens your blood or helps with clotting. So if cephalosporins have an anti-vitamin K effect, what does that mean? It means that they can cause blood thinning and bleeding. So you have to be really careful with patients who might be on Coumadin, warfarin, that type of thing on a blood thinner. You don't want to put them on a cephalosporin because some of these can have that anti-vitamin K effect. Or if you do put them on, you want to manage them very carefully and watch their PT, PTT, or their INR. All right, two more inhibitors of cell wall synthesis. Next one is carbapenems. These are used to treat MDROs or severe infections. They can treat both gram-positive and gram-negative bacteria. They can target both. They are administered by IV only, and the one you will see in the hospital setting, again, ICU, ED, sepsis, septic shock, that type of thing, is meropenem. Meropenem, and that's the generic name. So make sure that you're aware of that. There are others, but that's the one you're going to see the most when you're coding. Vancomycin is not a class of drug. It is the name of a drug, but it falls under a drug that you really need to know about that's an inhibitor of cell wall synthesis. Vancomycin, or Vanc, is used for severe bacterial infections that are resistant to penicillins and or cephalosporins, or for patients who can't have penicillins or cephalosporins. Because remember, patients can have an allergy to penicillin, which makes them sensitive to having an allergy for cephalosporins. And if you can't do penicillin or cephalosporin, what can you do? Vancomycin. Vancomycin works especially well on bacterial infections in the GI tract, like C. difficile. That's the drug of choice. If you've got a C. difficile infection, vancomycin is the drug of choice. Administration route is crucial with vancomycin. If you're going to use it on the GI tract, you have to give it orally. If you're using it for any other type of infection in the body, you have to give it IV. So make sure you know those details about vancomycin. And yes, I've had vancomycin, and it does pretty much kill everything. I had it after one of my C-sections, or they gave it to me as a prophylactic antibiotic with my C-sections. And yes, I did end up developing C. difficile because it killed all the good bacteria in my GI tract, but that came down the road. All right, so quick quiz questions. What are those 4 major types of antimicrobial drugs that inhibit cell wall synthesis? I give you the 4th one, which is vancomycin, but you should know the first 3, so make sure you know that. What type of bacteria do penicillins and cephalosporins target? Is it gram-negative, gram-positive, or both? How are penicillins categorized? How are cephalosporins categorized? What are the 4 generic names of penicillins we studied, and what are the 4 brand names of cephalosporins that we studied? What is the most severe side effect of penicillins? True or false, there is a cross-allergy between penicillins and cephalosporins, meaning that if you're allergic to penicillin, you may also develop an allergy to a cephalosporin, and vice versa. True or false, some cephalosporins can have anti-vitamin K effects, causing blood thinning or bleeding. What are 3rd-generation cephalosporins most often used for? Hint, 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 we talked about this. What are 4th-generation cephalosporins most often used for? We talked about this as well. What does the abbreviation MDRO stand for? True or false, carbapenems can't treat both gram-positive and gram-negative bacteria. If you're not sure about that with carbapenems, go back and look. True or false, carbapenems are usually given IV. What is the generic name of a carbapenem that we studied this week? It's the only one that we studied under carbapenem. What is vancomycin used to treat? True or false, if vancomycin is given orally, it only works on the GI tract bacteria. It only works on GI tract bacteria. True or false, if you had an MDRO or very serious infection, you would want to be treated with Rocephin, cefepime, meropenem, or vancomycin based on how they are designed to work. Please make sure you recognize these 4 drugs. I'm going to give you the answer on this. It's true. These 4 drugs are the ones you will see most often used on patients in the ED with sepsis, in the ICU with serious infections. They are heavy-duty drugs that they give. All right, inhibitors of protein synthesis. There are 4 of these we're going to study, and the first one is aminoglycosides. Aminoglycosides. These are effective on gram-negative bacteria. That's what they target, gram-negative bacteria. They're usually given IV or IM because of poor GI tract absorption, so make sure you know that. Aminoglycosides are going to be IV or IM because they don't absorb well in the GI tract. 2 generic aminoglycosides you need to know are gentamicin and tobramycin. And watch out, gentamicin, look at that. It's ICIN, not MYCIN. I made that mistake earlier and went back and double checked it and was like, oh yeah. So gentamicin and tobramycin, just watch that spelling issue and make sure you recognize those as aminoglycosides that work on gram-negative bacteria. They're given IV or IM because of poor GI absorption, and they are known for causing 3 types of toxicity: oto, which is ear, nephro, which is kidney, and neuromuscular. So you need to know that aminoglycosides, they have to be very carefully watched because they are known to cause ear toxicity, kidney toxicity, and neuromuscular toxicity. Oto, nephro, and neuromuscular. Second type of protein synthesis inhibitors we're going to talk about are tetracyclines. These are also effective on gram-negative bacteria. They target gram-negative bacteria. They are usually given orally, but sometimes their absorption in the GI tract can be impaired depending on how much food is in there and the types of food that's in there. So tetracyclines are a little bit touchy about what you're eating and when you're eating it when you give the drug, in terms of how well it will be absorbed and how much of it will be available to fight off the bacteria in your body. Tetracyclines are really easy to remember because look at that. When you look at those generic names, tetracycline and doxycycline, you see that cycline, so automatically it's going to cue you in. That's a tetracycline. They are known for causing tooth staining and bone growth retardation and photosensitivity. So you have to be really careful with these as well because they have those side effects where if someone has some bone growth going on, it'll be slowed down or stopped, and then they could have that photosensitivity to light, sunlight especially, and then they can have some staining of their teeth. All right, the last two we're going to talk about under protein synthesis inhibitors are macrolides. Macrolides work on gram-positive bacteria, so that's different than the other two. These work on gram-positive bacteria. They are usually given orally, so macrolides, think orally. There are three generic names I want you to be familiar with: erythromycin, clarithromycin, and azithromycin. Look for that THROMYCIN. THROMYCIN. And that will clue you in. These are macrolides. Okay? Azithromycin, many of you have probably already heard of this and or taken it, but the brand name for azithromycin is Zithromax. Has anyone ever had a Z-Pak or taken Zithromax? Well, you've taken azithromycin. That's the brand name for it. Macrolides are frequently used as antibiotics because they are very safe. About their only side effect is occasional GI upset. So compared to the other antibiotics that we're studying this week, the antimicrobials, these are really nice, sweet, kind ones in terms of their side effects. And so that's a lot of times why you'll see these prescribed. So make sure you're familiar with macrolides. They target gram-positive bacteria. They're only usually given orally. You need to know erythromycin, clarithromycin, azithromycin, and side effect. They're relatively safe. It's occasional GI upset. All right, the last protein synthesis inhibitor we're going to talk about is clindamycin. And again, this is a single drug, not a drug class. Clindamycin. It is very similar to erythromycin. So kind of keep that in mind that this is sort of a similarity to that. Also effective on gram-positive bacteria, targets that, but it can be used on some MDROs. So that makes clindamycin a little bit better than macrolides and some of the others, because again, it can be used for MDROs. It's usually given orally. Downside to clindamycin is it can cause C. difficile because it goes in there and it kills all the good bacteria as well as the bad bacteria when you're talking GI tract. So that is a side effect that it can cause C. difficile. All right, so quick quiz questions. What are the four major types of antimicrobial drugs that inhibit protein synthesis? And again, I give you that fourth type that's a single drug, and it's clindamycin. What type of bacteria do aminoglycosides and tetracyclines target? Is it gram-negative, gram-positive, or both? True or false? Aminoglycosides are the only type of antimicrobial drug that inhibit protein synthesis that are not given orally because of poor GI tract absorption. Remember, we talked about this. So if you're not sure, go back and look at aminoglycosides. You need to know why they're not given orally and the fact that they're not. I gave you the answer there, but I'm sure that you will remember that, right? Because you need to know that for your quiz. Name two aminoglycosides, their generic names. What are the three toxicities that aminoglycosides can cause? We covered that too, those three toxicities. True or false? Tetracyclines usually cause GI upset as a side effect. We talked about this. Go back and double check. That's what I'm saying. All right, name two tetracyclines, their generic names. And of course, this one's really easy because one is tetracycline. So you just have to come up with the other one. All right, what type of bacteria do macrolides and clindamycin target? Is it gram-negative, gram-positive, or both? Name 3 macrolides, the generic names. We talked about that. True or false, macrolides are known to cause tooth-staining, bone growth retardation, and photosensitivity. Really? Really? Is that why they're so often used? You might want to think twice on that one. Which type of antimicrobial drug inhibits protein synthesis is used to treat MDROs? Because we talked about one that is used to treat some MDROs. So be thinking about that. And which type of antimicrobial drug that inhibits protein synthesis can cause C. difficile as a side effect? Hint, hint. Not the answer to number 4 and the answer to number 5 is the same thing. So if you're not sure, go back and take a look. Sulfonamides. We are almost done, so hang in here. We're on the second to last drug class here. Sulfonamides. Your book lists them as a folate antagonist, and when I did some additional research, I found that that's not true. They really aren't. Metformin is a folate antagonist, and sulfonamides are not metformin. So we need to ignore the book when it calls sulfonamides folate antagonists. So kind of strike that from your memory. Sulfonamides are effective on both gram-positive and gram-negative bacteria. It can target both. It's usually only given orally or applied topically. So make sure you know that. Sulfonamides are given orally or applied topically. You don't need to know the names. I give them to you here, but you don't need to know them. Typically, sulfonamides are given in pairs. Just FYI. Sulfonamides are known for causing hypersensitivity reactions, urinary issues, and hematologic reactions. So make sure you know sulfonamides are not nice things. They can cause hypersensitivity reactions like penicillin, which is anaphylactic shock. They can cause urinary issues and hematologic reactions. Not good. All right, last one, fluoroquinolones. The book labels them as just quinolones, but again, when I did some research, that's not the case. You need to know these as fluoroquinolones. So ignore the book if it just calls them quinolones. Fluoroquinolones are divided in terms of group by older versus newer. Older group is ciprofloxacin. That's the generic name. It's known as Cipro as the brand name. Easy to remember, hopefully. Newer group is levofloxacin. It's a generic name, and Levaquin is the brand name. You will see ciprofloxacin and levofloxacin, and you will see Cipro and Levaquin in medical record charts. So make sure that you are familiar with these fluoroquinolones, both the generic name and the brand name. Fluoroquinolones are effective on both gram-positive and gram-negative bacteria. They are usually given orally or parenterally, and they are known for causing severe toxicities in your GI system as well as your central nervous system. So they usually try and monitor people that are on fluoroquinolones a bit closely because there are severe GI or central nervous system toxicities that can happen. All right, last set of quick quiz questions, I believe. What are the last 2 types of antimicrobial drugs we studied this week? And hint, the book did not label either one accurately, so try and use the most accurate that we came up with. True or false, sulfonamides and fluoroquinolones, see I give you the answer to the question before, are effective on both gram-positive and gram-negative bacteria. This is actually true, but if you're not sure, go back and double check. You need to know what kind of bacteria sulfonamides and fluoroquinolones target. How are sulfonamides administered? Hint, it's 2 ways. What are some of the serious side effects of sulfonamides? How are fluoroquinolones grouped? And then I give you the answer in the next 2, but that's all right. Name 1 older group drug, both the generic and brand name. Name 1 newer group drug, both the generic and brand name. How are fluoroquinolones administered? Hint, it's 2 ways, and one is the same as sulfonamides and one is different. What are some of the serious side effects of fluoroquinolones? We talked about that too. There's 2 systems that fluoroquinolones can really cause some toxicities to. Make sure you know what those 2 are. And then the last one, true or false, sulfonamides and fluoroquinolones are often used to treat MDROs. Are they? Are they not? Double check if you're not sure. Go back because you really need to know which are the drugs that do treat MDROs. All right, that is it. We're at the 45 minute mark. I hope you have a fabulous week. If I don't see you or talk to you before you head off on spring break, I hope you have a fabulous spring break. I look back to coming and talking to you the week after spring break. We'll be on week 10, and we will be discussing drugs used in tuberculosis and leprosy, antifungal drugs, antihelminthic drugs, antiviral drugs, and antiprotozoal drugs, as well as anti-cancer drugs. So we will have some exciting topics to talk about. Take care. Bye.